The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we are thrilled to have Dr. Snyder here to review general intraoperative considerations. Dr. Snyder is an acute and critical care surgeon at Washington University in St. Louis.
Hi, Felicia. Thank you so much for having me. I'm excited to speak with you today about our chapter.
My name is Felicia Zhang, and I am a general surgery resident who will be your host for this episode. Although each patient disease and operation is different, there are general principles to follow in the operating room. Today, we will go through each of the following steps of any operation, which are team introductions, timeout, anesthesia, positioning, preparation and draping, the operation itself, intraoperative complications, extubation, and the handoff. Now let's dive right into a case scenario to guide our discussion. Dr. Snyder, a 55-year-old patient is wheeled into the operating room for you to perform an open right inguinal hernia repair. What is one of the first things you do when you walk into the operating room for an elective surgery?
Well, when I first go into the operating room, I like to make sure I introduce myself to everybody and make sure I know everybody that's working with us, especially when there's new faces around. And so it's important to know everybody's name.
And why is that?
Well, I think it really helps your ability to kind of communicate, just generally, but also critically when something's going wrong, kind of knowing who to ask for and being able to kind of stay focused when not worrying about, figuring out who you're asking for and things like that.
Okay. Sounds great. So in our scenario here, everyone introduces themselves, they know everyone's names, and it's time to start. What's next?
Well, a critical element, certainly in this day and age, is the timeout before starting surgery.
And why is a timeout important?
Well, again, in this day and age, we certainly want to minimize patient complications. And so one of the things that's been demonstrated to be effective in reducing things like wrong site surgery is the timeout, ensuring we have the correct patient, we have the correct procedure, the correct site, as well as consent from the patient, and kind of this is the opportunity to communicate with the nurses, with anesthesia, kind of what your plans are, any anticipated needs for during the surgery, expected specimens, things like that.
Okay, so we do all that, and then anesthesia would like to ask what type of antibiotics we need to give.
Well, for this case, I think, certainly a inguinal hernia, typically, we're mostly worried about skin organisms. So we typically start with Ancef or cefazolin. Certainly if we were doing a case where there was concern for bowel involvement, perforation, anywhere where we're going to be in direct, contact with the GI tract, broadening that to cover things that would be seen within the bowel lumen, antibiotics that might be used. We oftentimes use ertapenem. You can also consider cefoxitin, or using Ancef plus Flagyl is also sometimes used. Great. And one last point too, I think the importance, understanding kind of your institutional antibiogram is really important for sort of understanding what's out there and what may or may not work, so specifically where you are, because that can definitely vary from place to place.
Great point. So we choose Ancef. This seems to be a pretty uncomplicated inguinal hernia repair. How about the timing of the antibiotics?
Well, we like to give antibiotics within about an hour of incision. They're typically given kind of right before incision, and they're typically redosed with respect to the patient's or the agent's half-life. And also you can consider it redosing if you're having significant blood loss, as that'll obviously reduce your circulating volume of distribution.
Great. So Ancef is administered within 1 hour of our incision, and hopefully we do not need to redose for this case. All right, so the anesthesiologist now starts preparing to perform a MAC, which stands for Monitored Anesthesia Care. Dr. Snyder, can you tell us what the difference is between a MAC and general anesthesia?
So a MAC anesthetic, or monitored anesthesia care, is typically something that's performed for cases where you don't need complete paralysis. A sedative medication is given. However, the patient is able to breathe on their own. Sometimes they require using an oral airway or a nasal airway to maintain to help them breathe. But typically, this is the patient is not intubated for MAC, and they are receiving oxygen by a face mask, and IV sedation is being provided, but they're not, the inhalational anesthetics are typically not used for this. Additionally, they're also monitoring end-tidal CO2.
Gotcha. So the patient here actually keeps coughing and moving despite increasing sedation. The anesthesiologist tells you this is the max sedation they'd like to give before they start worrying about oxygenation. What do you do now?
Well, certainly trying to do a case under MAC, sometimes can save some of the concerns you might have about some of the risks that you might have about general anesthesia. However, you would certainly need to make sure that you've prepared the patient that they may need to undergo general anesthetic if the MAC is not providing satisfactory anesthesia. And so, definitely preparing them that intubation and general anesthesia is kind of on the table would certainly need to be discussed with the patient ahead of time.
Mm-hmm. Okay, so we move forward for intubation under general anesthesia, but unfortunately, right after induction, the patient becomes hypotensive. What could be the differential here?
Well, oftentimes when you see hypotension after induction, it's typically a transient hypotension that resolves relatively quickly over the course of several minutes. Oftentimes that can be simply related to the effects of the induction medications. For example, propofol is frequently used as an induction agent, and that's known to have an effect on hypotension. Etomidate, you can also see that. The other thing to remember too is that with some of the loss of that vasoconstrictive tone, especially if the patient is fluid down, for example, if they've been NPO after midnight, haven't had anything to drink, they're a little dehydrated, and then their vasculature dilates. You can see a profound drop in their blood pressure. Oftentimes it's treated with fluids or a transient dose of vasopressors, and gradually the patients resolve and come back to normal.
All right, so the patient's vitals have kind of resolved on their own. They're now normal. As we are talking about general intraoperative considerations in this chapter, we won't talk about specific prep for this operation. However, can you give general principles of positioning?
Well, I think, typically just kind of thinking through the case ahead of time, I think is really important. So kind of understanding your different positioning options, especially if we're, doing, as a general surgeon, we do a wide variety of procedures and a wide variety of positions. And so, kind of supine is probably the most common, which you'll be undergoing for things like a laparotomy, probably for this hernia repair. You can also bring the patient's legs and put them into stirrups and have their legs out, which would be called lithotomy positioning. That, again, has its own set of considerations, and that's oftentimes used for things like colorectal or OB-GYN. We'll also sometimes put patients on their side, which would be, if they're right side up, that's left lateral decubitus, and that allows you to do things like a thoracotomy or work on some sort of an issue on their flank. And then finally, prone is another commonly performed form of positioning. Oftentimes we'll do that for anorectal cases or if they're sacral wounds, things like that. There's a number of other sort of very, very specific positions that ENT neurosurgery may use that are probably beyond the scope of this discussion as well. Other things to think about for positioning, however, are also thinking about making sure the patient and the bed itself is centered underneath of the OR lights, because the OR lights are sort of configured to sort of work around that point in the room. Being mindful to pad pressure points, arms, legs if they're in the lithotomy stirrups. And then also, once you've kind of had the patient secured and on the bed in the position you want to work on clearing your sheets, cords, tubes away from the bed side rail, especially if you're going to be using a self-retaining retractor like a Bookwalter or an Omni, because those devices need access to that side bed rail. And if there's a bunch of sheets or blankets or Foley catheter, tubes next to that, it's just going to make it harder once you have your drapes down to get access to that.
All right. It seems simple, but pretty complex thinking behind some positioning. And one last question about positioning. What do we do with the arms usually? Why do we do arms out versus arms in?
So the arms out are usually, that usually gives anesthesia the best access because that's typically where their IVs are. And so that gives them access if there's problems, if there's hypotension, they want to put an arterial line, or if they want to put a new IV because it's not working, that gives them the best access. They also have better access for blood pressure cuffs. So all things being equal, I think the anesthesiologists prefer the arms out, and certainly if you can oblige them, I think that would be helpful. However, there are times where you're doing things like, for example, a laparoscopic ventral hernia or potentially appendectomies, where sometimes we will tuck the arms to allow access to sort of further up along the patient's side. That gives you sort of greater range of access. But it's you have to be thoughtful because when you tuck those arms, you can end up injuring, the nerves on the arm as they're positioned. They can you can have pressure on those nerves that can cause palsy subsequently.
So in this case, the patient is now properly positioned, supine arms out, and we're ready to begin the prep and drape. Now, why is prepping important?
Well, prepping is important because obviously anytime you're making a skin incision, that's a break in the skin, which is a natural kind of protective organ to reduce the risk of entry of bacteria. And so you can develop surgical site infections postoperatively if you're not appropriately prepping. So that's definitely something that you want to make sure that as the surgeon, as the resident, you're kind of monitoring it happen. Make sure, especially if you have some new staff that are doing this, or junior residents that are doing this, you want to make sure you're watching them because you want to make sure they're doing it sort of as broadly as you would need for the surgery. So the clipping is kind of typically how we start, removing hair. Ideally, we avoid shaving, prefer to use clippers because there's less trauma to the skin, and then subsequently applying the topical prep.
Well, it seems pretty intuitive why we need to prep. We want to prevent surgical site infection. But Dr. Snyder, why do we need to drape?
Well, draping is important component of prepping because it sort of also contributes to keeping the surgical field sterile. Drapes allow you to kind of isolate the area you're working, and the drapes themselves are sterile, so it prevents your sterile gloves, your sterile gown from contacting anything that's not sterile. It also is helpful because it's another cover. It helps keep the patient warm, which is a critical element of maintaining normothermia is important for reducing surgical site infections. And also, it also does a nice job protecting the team from spillage of blood and fluids. So it's kind of a two-way streak there.
Mm-hmm. Okay, so we are prepped, draped, and we're finally ready to operate. Can you go over the general steps to any operation?
So obviously, your mileage may vary based on kind of the type of surgery you're doing, but I think there's a couple sort of broad strokes for this. Typically you're going to get access to the area you're working. You're going to explore that area. You're going to perform your dissection. You're going to perform a resection as needed, of whatever pathology you're going after, whether that's a cancer or a abscess or a hernia, followed by a reconstructing kind of what you've removed. And then subsequently, the final is the closure is the last step.
So we're beginning to operate. However, we just begin our dissection when we encounter some bleeding. What do we do?
Well, we don't freak out. We calmly place a finger over the bleeding area or apply some pressure with a sponge, and then slowly take this off to identify what's truly bleeding.
Great. So you do this. You take your sponge off slowly, and a vessel is visible. What do you do now?
So there's a number of options we have for stopping bleeding. So certainly in a working through the subcutaneous tissue in an inguinal hernia, potentially just apply, electrocautery to it versus grabbing it with a DeBakey and applying electrocautery to that. But I think kind of just broadly, because again, the point of this talk is also to sort of look at some other considerations in other types of cases. There's a number of options for delivering energy to provide hemostasis. And so I think probably the most commonly used one, right, is the hand control cautery, which is a monopolar device, meaning the electricity travels from the handheld device, the pen, as some people call it, and then it travels to a pad that's on the patient's, typically on their patient's thigh or buttock in an area without any metal implants, and it creates a circuit that way. The other sort of alternative cautery that's also commonly used is what's known as a bipolar. This is more frequently used in neurosurgery and head and neck type procedures, but basically what that means is that there's a single forceps that has basically two contact points and controlled by a pedal, but basically the electricity travels between those 2 points on the forceps, so there's not a need for a separate grounding pad, and that reduces thermal spread because the electricity is only traveling between the 2 points of the forceps. Moving beyond that, more advanced cautery techniques or devices, we also have what's called the ligature, which is kind of an advanced bipolar device that can seal vessels that are several millimeters in size. There's the ultrasonic devices, which use sort of vibration to cause a sealing of vessels. That's the harmonic scalpel. And there's open and laparoscopic versions of both the ligature and the harmonic. And then there's also a combined ultrasound with bipolar device, which is the thunderbeat. So that's kind of the broad. That's kind of the smorgasbord of options you've got for stopping bleeding with devices. And then finally, right? I mean, also don't forget you can also grab the vessel, put a clamp around it, and tie it off, and you don't have to use any electricity.
Yeah. Although I'm still waiting for my opportunity to use the thunderbeat.
I know.
So say this was a redo mesh repair, and after mesh excision, we see a lot of raw surface bleeding. What now?
So, ideally identifying kind of what's bleeding, ensuring that there's, if it's a discrete point of bleeding, you can throw a stitch in it, you can apply a hemostatic agent. However, sometimes you just have a lot of bleeding from a broad area, and it's not necessarily something that you feel comfortable just applying, cautery over the entirety of the wound. And so there are topical hemostatic agents that sort of activate or supplement the coagulation cascade and allow the clot to form without applying energy to the field. And so, probably the most commonly used hemostatic agent is what's called Surgicel, and it's a oxidized regenerated cellulose. And what it does, in essence, it kind of absorbs the fluid and brings those factors, it concentrates the factors and allows them to form a clot. And it can be pretty effective for a lot of different wounds. But it doesn't always work, especially if the patient is coagulopathic from the get-go. They may not be able to generate the fibrin that you need to eventually make a clot. And so there's more advanced options, such as fibrin sealants. That's like the Tisseel. Everest is also a type of fibrin. It's actually a fibrin patch, which is placed on it's fibrin that's actually placed onto a Surgicel patch. That can be tremendously effective. The only downside to these fibrin sealants are they are tremendously expensive, on the order of hundreds to I think close to $1,000 for basically one dose of it. But obviously, if you're dealing with life-threatening bleeding, it's worth it. But certainly not something you want to just break out for every case where you have a little bit of bleeding.
Yeah. Thankfully, that was just a hypothetical scenario. We don't actually need to apply any of these expensive hemostatic agents. And we're moving through the case pretty well. We're now sewing the mesh in. And unfortunately, your resident accidentally takes a huge bite with her needle. Dark blood starts welling up. What do you do?
I think the first thing you do is you're going to hold some pressure, kind of assess and, kind of look and see kind of figure out the trajectory of the needle and kind of make a decision about what you're worried about. Certainly, if you're kind of at the floor of the inguinal canal, and this is done, you certainly worry about the femoral vessels. And so sometimes you have to take the mesh up, cut out your previously placed sutures, expose your femoral vessels by opening up the floor and then applying pressure to that area. Typically, if you have an injury to these vessels, usually if it's just a puncture injury from a needle, you're usually able to hold pressure and it usually stops.
Mm-hmm. Okay. So you find that the femoral vessels look fine, but a branch was avulsed, and then you ligate this and are able to stop the bleeding.
Awesome.
But unfortunately, anesthesia now alerts you that the patient has lost a whole liter of blood while you've been searching for this vessel. And the patient is now tachycardic and hypotensive. Do you want to give blood products? And if so, what type?
We got a patient that had bleeding. We've controlled the bleeding. There was an identifiable injury. We were able to fix it. In this situation, I'd probably give a unit of packed red blood cells. But I think an important thing to remember, right, if somebody's bleeding and you notice that they're coagulopathic, simply replacing their lost blood with packed red cells is not always the right answer, especially if you're dealing with a coagulopathy. And that's where things like a balanced resuscitation becomes really important. And that's just something to think about.
Mm-hmm. So hopefully not needed in this case, but if the patient did need a massive transfusion, what is the balanced resuscitation you're talking about?
Well, so the ratio of packed red blood cells to plasma and platelets we found is important, and there's been several large studies that have helped kind of guide how we do resuscitation. And again, I'm coming to this as a trauma surgeon, but I think there is some crossover even in general surgery fields where when you're dealing with massive bleeding. And so I think kind of the first study that came out was PROMPT, which was a study basically looking, or it was able to identify that patients that got more plasma with every unit of RBCs, this is that higher ratio led to higher survival. So folks that got 1 unit of plasma with every unit of PRBCs had a higher survival when compared to patients that had, for example, 1 unit of plasma for, let's say, every 2 or 3 or 4 units of PRBCs. And so we found that sort of bringing it a little bit closer to a 1-to-1 ratio had a higher survival. And then PROPER is the next study that was done to sort of confirm this finding, and identified, they looked at a 1-to-1 ratio, meaning 1 FFP for every 1 of PRBCs versus a 1 FFP to every 2 PRBCs ratio. And they found that there was faster hemostasis and less blood required in that group. However, unfortunately, this study did not demonstrate a difference in mortality at that 1-to-1 versus 1-to-2 ratio. And so I think there's still some question about kind of the study design, but still appears to show a signal that there's some benefit to that. The other thing to think about, right, is now in 2024, we also have the availability of what's called whole blood, where we're not even worried about the different components. We just give, blood that has been taken from donors. It doesn't get spun down into PRBCs, FFPs, and platelets, and rather is used simply as the entirety of the blood would be donated. And this is really important because it has it has everything sort of that would be in blood. And I think if you think about it, right, bleeding patients bleed blood, they don't bleed PRBCs and FFP. And so giving them back whole blood appears to be a beneficial thing that we're doing. And there's a lot of research coming out that it appears to be helpful.
Yeah. So the resident, she wants to redeem herself and impress you with her extensive knowledge of the patient's clinical history. And she remembers that the patient has von Willebrand factor disease. She thinks it's type 1. Would you consider giving cryo or desmopressin?
So, the von Willebrand disease, I think type 1 has decreased concentration and decreased activity of the factor. If you have small bleeding, you can give DDAVP, and that'll cause the body to sort of release more von Willebrand factor. However, cryoprecipitate is going to give you that exogenous von Willebrand factor along with other factors. I think I should also make note there's also some other options as well that are just concentrated von Willebrand's factor. That's also another option in these patients. I would certainly think about consulting a hematologist, if you have patients like this, to sort of help guide some of the management of these patients and make sure they're as optimized as they can be preoperatively.
Mm-hmm. And finally, the resident also reminds you that the patient has ESRD. What are we worried about here if the patient continues to bleed?
Well, I certainly want to make sure the patient's up to, receiving their dialysis as regularly scheduled, because you want to make sure that, they're not uremic, because this can lead to inhibited platelet adhesion and aggregation.
So at this point, let's enter another hypothetical scenario in which we're closing up, but the patient becomes hypotensive yet again. And there are some arrhythmias on the monitor this time. As this is an open inguinal case, your resident has been faithfully injecting lidocaine, but you realize that no one has actually kept track of how much has been injected. What do you think is going on here, and how would we treat it?
Well, given this scenario, I would definitely be worried about lidocaine toxicity. This is something, if this occurs, you certainly want to make sure you're maintaining airway and cardiovascular support. One therapy for this in folks that are demonstrating sort of cardiovascular collapse is an IV lipid emulsion therapy that you can give emergently that can be helpful. But, we'd need to keep the patient intubated certainly going to the ICU until they're able to stabilize. I think just as a learning point, right? I think definitely discussing with, the anesthesiologist, hey, what's a suitable dose of our topical anesthetic? And they're usually able to sort of help you make a decision there. And I like to have that conversation with them too, because also it's important to sort of discuss what they anticipate, sort of how the patient's doing, how they're responding to the surgery, if they need additional pain control, things like that.
So the patient is under general anesthesia at this point. CNS toxicity would be hard to gauge. If the patient were awake or mildly sedated, what signs or symptoms would they have that could clue you into lidocaine toxicity?
So, kind of some of the first stuff you can see are dizziness. Sometimes patients will report a paraoral numbness or a metallic taste. And they can also have some visual disturbances and seizures, obviously at worst, that might warrant some further, critical care.
Mm-hmm. And then finally, what could be done differently to prevent this sort of scenario in the first place?
So obviously understanding kind of the suitable safe dosing for topical anesthetics. I think the 1% lidocaine is typically dosed at 4 mg per kilogram. Lido with epi is going to allow you to sort of give a higher dose because the epinephrine causes vasoconstriction, so there's less distribution systemically, and it makes it a little more gradual effect. And, also just kind of better communication with the team, keeping track of how much you're giving, letting anesthesia know how much you're giving so they can kind of monitor for that. Something also to remember, I'm a big fan. I like to use 0.25% bupivacaine. Certainly in somebody that's under anesthesia now, dosing is really easy because it's 1 cc per kilo of ideal body weight. So I often go with that, especially if if the patient's under and you don't need immediate pain relief, because the bupivacaine obviously takes a little bit longer to onset compared to the lidocaine.
Gotcha. Good to know. 1% lidocaine is not your only option, guys. Okay, so thankfully in this case, lidocaine toxicity wasn't an issue, as we had established great communication with our team prior to starting the case, and we knew when we had reached our lidocaine limit. We have now closed our incision, and anesthesia is working on extubating the patient. However, they are having trouble with emergence. What could possibly be the issue here?
Well, there's any number of issues, that can lead to difficulties awakening from anesthesia. Certainly thinking about things like, if they have renal or hepatic issues that may affect metabolism of medications. They could also have issues with COPD, hypercarbia or hypoxia. They could also have systemic problems like hypoglycemia. They could be cold. As well as electrolyte abnormalities may have some sort of effect there. And certainly, worrying about neurologic complications like a stroke, certainly want to rule that out as well.
So lastly, after the operation, it's important to make sure the patient gets to their postoperative destination with correct and timely orders, and to communicate to the rest of the care team what has happened in the operating room. This comes in the form of operative notes by the surgeons and handoffs to the patients, often multiple care teams. Dr. Snyder, what are key components to a good surgeon's handoff?
Well, the handoff's super important. Letting the team that's taking over understand the procedure performed, kind of where the incision is, talking about any drains you may have left, what the plan is to manage them. Explaining we're looking for bile if we put a drain next to the gallbladder, and the surgical team needs to be notified if anything green's seen in the drain. That sort of thing, or if there's a significant amount of blood coming out. Sometimes we'll also leave drains if we're dealing with a cirrhotic, and so we may provide them with precise instructions regarding how often to empty the drains so that they don't, cause the patient to become hypovolemic from draining the ascites too frequently. Something else to discuss are any intraoperative complications to just make sure, the floor team or the ICU team kind of understands what happened in the OR. And then also kind of going over expected postoperative course. Are they expected to go home tomorrow? Are they going to be here for a week waiting for a return of bowel function, that sort of thing. And then also, what your plan for postoperative analgesia is, whether that's a PCA, whether that's PO medications. Just make sure they're aware of kind of what you're anticipating they're going to need, and also kind of explaining sort of the amount of dissection that was done, and if you anticipate sort of a higher than normal amount of analgesia needed. And then finally, disposition. Is the patient going home today? Are they going to need to be here for a while? Or do they need to go to the ICU? All of those things are really important to review.
Great. So We are done with the case. Thank you, Dr. Snyder, so much for being with us today. We got through a ton of great information about intraoperative considerations. We couldn't possibly cover everything today, so if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes and read the full chapter in the Washington Manual of Surgery.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.